Thank you very much. Thank you for the invitation to be here, and thank you all to join this lunch symposium. These are my disclosures. And of course, you already seen this slide probably many times. I would like to take the standpoint of the patient, which is always what I find most interesting for whatever research we are doing. And the primary outcome of the discharge trials, you can see here that the blue is the CT strategy, and the red is the cath, invasive cath. And there is a trend that it's better to do CT. And of course, if we had hoped that that would be significant, when it wasn't, we're still looking for what the outcome will be on the long term. But I would also point to this very important slide where you can see that obviously the procedural complications, if you choose invasive cath as the first choice in patients with chest pain and intermediate likelihood, that's not a good idea. You should do CT, and I think we'll stop discussing this after the discharge trial. I would like to draw your attention to the appendix of the paper, where you will find this very important clinical management slide, where if you start here, obviously if you don't find any significant or so-called significant disease, you can discharge the patient. Whereas if you're here, you have NDX, that means non-diagnostic. Obviously none of us have ever seen a non-diagnostic CT. That's a joke, yes. Or if you have one or two vessel disease, that leads to an imaging test of ischemia. That was the foundation for the strategy in the discharge trial. I think it's quite important to understand this, because what it means is that quite a large number of the patients in the discharge trial needed ischemia testing. And what you can see here is that if you enter the CT arm at 1 year, 15% of the patients needed an ischemia test. And what happened then was that they had much less revascularization, and still the major clinical outcome was similar, and they had the same symptomatic status at 1 year. So to achieve this, probably in 15% of the patients, we would need some more testing than just the CT. As I said, we never have non-diagnostic testing, and this is just some experience we had from the verdict trial, where you can see that it really also depends on the technology that you use. Overall, 5% of the patients in the verdict trial had non-diagnostic tests, but if you look at the technology that was used, if you do use wide volume detectors, it becomes even lower. And I think that's important for any understanding of how each of the centers, how they decide what they want to do with patients with chest pain. Of course, you all know this. You can do CT by two approaches, prospective or retrospective. And why is this of relevance? Well, it is because already now, if you're doing CT angiography, you can get an image like this. You're familiar with this, and obviously some of you also will be familiar with this, that if you play around with the window level, you can appreciate that there is hyperattenuation here, which of course is consistent with that this is an occlusion. I just use this example, which is not clinically so fantastically interesting, and just showing that how static perfusion imaging is done. And so that was our first experience with this particular approach, that on top of angiography, you would want to pick up if you could get some more information on what is happening in the myocardium. And we actually entered a randomized trial some years ago, and it was including rest perfusion and adenosine perfusion with CT. And that was really rewarding, that you could see that if you use CT alone as compared to CTA with CT perfusion, the referral rate for invasive cath was much slower. And as also the proportion of patients ending up with revascularization was the same. And pretty much similar to the discharge trial, we didn't find any differences in the really important things for the patient, namely the clinical outcome. This, of course, is very interesting for physicians, but the patients do not care about this. They're interested in how will they, have a better life after you treated them. So you can actually achieve this by doing a static perfusion. There are some caveats here. This is examples of how you do it. And of course, you may or may not be able to see these hyperperfused areas. I'm just trying to make a point that this is not easy. And any technology, if it cannot be done in all places where patients have chest pain, it's not really helpful. We want techniques that anyone can do, otherwise it's not helpful for the general community and the patients. And just to point to some of the other aspects of static perfusion that you will encounter. If you have motion or if you have beam hardening, that just makes it even more difficult to figure out if a patient has a perfusion defect. So I was so happy to see that the CT technology evolved further. Now that we can do dynamic testing, meaning that we can do sequential acquisition of the myocardium at rest and during adenosine. And of course, this is just for fun. Just let me show you one of these examples. Don't do it at home. This is a very difficult pediatric case or congenital heart disease patient where we did sequential acquisition, of course, with a very small C-axis to keep down the radiation. It's just to explain to you what is obtained by doing a dynamic sequence of imaging with the CT scanner. What is much more interesting is if you reduce the settings so that the radiation is very low, this is actually doable with the current CT technology so that you can record the input curve. I mean, how is the contrast supplied to the heart, and what are the extraction of different regions of the myocardium. That is the basic understanding of how you can measure blood flow in doing dynamic perfusion imaging. Is it easy? Well, this is one of my PhD students that did this slide. He spent 3 years trying to figure out what would be required to be able to do this, and there are so many factors here. I don't want to get you bored and go through all of them, but we went through the literature and we did our own experience. And would you be interested in setting up your own system? You can read how our experience is and how you may or may not implement or set up a dynamic CT perfusion protocol for your particular center. This is how now it works at Rigs. And this is a routine protocol, meaning that I'm never there. Well, I'm only there because the adenosine is given. This is a stress agent. It's just for safety reasons. Everything is done by the radiographer, and it's very simple. It took some time to get there, but now it's a routine protocol. And as you will see later, we're using it for a full-scale science program. But of course, preparation, CT angiography, and stress perfusion, this is how we do it. We always do CT angiography first because that is the key thing for CT. You can get perfusion from other technologies, but CT angiography is the only test where you can give non-invasive coronary angiography. So we do everything to get that right, and if there's a need for it, then we can do the stress. A little case here, 72-year-old female, usual suspect, hyperlipidemia. She was admitted with chest pain. ACS was ruled out. But it came back a couple of weeks ago. We did the CT. Are we having fun? We are not having fun. This is very difficult to make a call. I'm sorry, it presents really poorly here, but what you can see is that it's severely calcified. So what did we do? Of course, we did the dynamic perfusion with adenosine. And this color scaling, if you're not used to this, it just means that it's a huge amount of blood coming to all regions of the myocardium. This is completely normal. It's a normal perfusion scan. Nobody have ever thought about that being normal when you see the first test. Of course, this was in the early days of our experience, so the patient had a cath. And behold, the FFR was negative in all coronary arteries. So had we trusted the CT perfusion, this patient would have avoided invasive cath, although the calcium scoring, I guess, was around 1,000. This is what you can get from doing perfusion. Another example here, I just skip really quickly here. See, there's a lesion here. We can all agree that LAD there probably is a serious problem here, but there's calcium right there. So by the vote of all, what would you do here? Do cath? Do nothing? We don't need to vote because I decided to do the perfusion. And this is a very neat feature. This is the angio overlaid to the perfusion. And of course, you can see here that that particular lesion was responsible for a smaller perfusion defect here in the apical region. And of course, you could argue, should we stop here? Well, some will say, clinicians will say, if you have a region of that small an area of ischemia, you're pretty much done. Some would say this is an LAD, it could be a prognostic lesion, but it's a mid-LAD, so if you can just handle the patient with medication, maybe you're fine. These are the new questions we have to ask ourselves if we implement this new technology. Of course, we love randomized trials, because that's how you really can tell if it's of value to use a new technology. And this is why we set up this yeah, it's a fantastic logo. I hope you like it. And this is a ridiculously long title, but it just means that we're looking at whether dynamic perfusion and to some extent also CTFR is helpful for outcome of patients. And we just launched this. And just to, these are all these standards that has to be in the protocol. First primary hypothesis is that we would look at clinical outcome and of course symptom relief and quality of life. The three most important outcome variables that patients are interested in. Not whether we can do the test or not. They're interested in having a better life after what we are doing. And the inclusion, we wanted the most difficult patients. Of course, they have had suspected ischemic heart disease, but should be older and maybe even haven't had earlier revascularization. Because now we know the easy patients, we can do that with CT angio in most cases. At least 75–80%, we're fine. But in some patients, the difficult ones, we need more. And this is why we selected this particular different type of patients. I'll just skip that, the normal exclusion criteria. It will be ongoing in the greater Copenhagen area, and sample size will be 2,000. And the standard routine randomization will be happening, and if they have the CT guided, that will decide whatever treatment they'll need. If they have conventional, that could be going directly to cath or whatever the physician feels is the appropriate approach. And okay, so the take-home messages for my talk is that coronary CT angiography is the new first test following the findings of the discharge trial. And so it will be a standard for patients with chest pain and suspected CAD. In a sizable number of patients, we have either non-diagnostic coronary CTA findings or borderline stenosis. So in those patients, we would still need more. And so dynamic CT myocardial perfusion imaging requires a dedicated logistical setup, but once it's established, it takes some time, but once it's established, it can be conducted routinely. And I think dynamic CT myocardial perfusion in combination with coronary CTA offers a logistically simple and comprehensive assessment in patients with suspected or confirmed CAD. Thank you.